welcome to the AO Trauma webinar series. My name is Jason Nascone, and tonight we're going to be talking about the pelvis and talking about posterior pelvic ring injuries and some of the ways to treat them. I'm joined by my esteemed colleague and close friend, Dr. Robert O'Toole. And for the next hour, what we're hoping to do is go over a series of cases and hopefully bring out a variety of learning points within those cases. There, you have the opportunity to ask questions if you like, and we'd ask you to do that within the question and answer section on Zoom, and we'll be monitoring that. And we also have it built for some time at the end to answer questions and have any discussions. So without further ado, we'll get started. So there's a variety of posterior pelvic ring injuries that we can see. They can be dislocations, they can be fractures, they can be combinations of those things. And so the objectives for the talk tonight are to, number one, recognize the variations in posterior ring injuries. The second is to help you create an inventory of reduction and fixation techniques for the posterior pelvis. And then lastly, to develop a decision-making framework for obtaining and maintaining the reduction of the posterior pelvic ring from a case-based discussion. So the idea is we've chosen some cases that bring out some learning points, and we'll walk through those. And there's a lot of different ways to treat these injuries, and we're going to walk through some of those ways and hopefully discuss the others. So the main injury patterns we're going to be looking at, there's really four. And so the first is an unstable, in quotes, posterior ring injury where the pelvis is reduced. And so this a lot of times falls into the gray zone area of the pelvis, or a posterior ring that you're worried about will displace. The second type is a sacroiliac disruption that's either partial or complete. So an APC type 2 injury or a type 3 injury. Thirdly would be fracture dislocations of the posterior pelvis, and this is a crescent fracture or an LC2 pattern. And then lastly will be sacral fractures, and the majority of these sacral fractures are some sort of lateral compression, but they can also be classified as vertical shear in some situations, but we're usually talking about complete sacral fractures. So we have a variety of tactics, and I'm sure everybody on the line tonight is aware of these, but this is sort of our toolbox of what we have. And so we have in situ fixation, or just putting screws into a pelvis and keeping it where it is. We have the ability to do a percutaneous reduction as well as percutaneous fixation. And then as we start going up the scale of invasiveness, we have open anterior reduction to the posterior pelvis, and we have an open posterior reduction to the posterior pelvis. And it's important to remember and not forget that some of these rotatory injuries, the anterior reduction really is useful in reducing the overall pelvis. And so it's going to be difficult to talk about a pure posterior reduction without just making some comment about the anterior reduction. So this is my tactic, and it's just a generalized way that I look at these pelvic rings. And there's a lot of different ways to do things, but this is sort of where I am now. So I want to try to create stability and do whatever's an easy reduction in the pelvis first. So if it's a bilateral injury, I want to start on the easier side, create some hinge point, some stability, and then work my way around. I like to get a provisional reduction of a rotatory injury. So if it's a rotational deformity, I'd like to correct that as best I can to help aid my posterior reduction. And then lastly, I'm usually going to try to attempt a closed or percutaneous reduction first. Now, it may be a pattern that I look at and I know I'm not going to be able to get it, but in a lot of these patterns, you're not really sure. And if you can get it reduced closed and get it fixed closed, that will be my preference. Now, if I have a poor reduction, or I'm unable to reduce the ring, or I look at it and I know that I'm not going to get it from the get-go, then I'm going to go to a more invasive means, and that'll be either an anterior open approach to the posterior ring, and that's going to be for sacroiliac dislocations and some pure fracture dislocations of that posterior complex, or a posterior open approach, and usually that's going to be for a sacral fracture or select sacroiliac dislocations and fracture dislocations. We'll have some cases where you could go either way, and we'll talk about that. All right, so without any further ado, we'll go into some cases. So this is a 56-year-old. He's involved in a motor vehicle collision. He's hemodynamically stable, and he presents in a binder. And so what we see on this initial AP image is we see some symphyseal diastasis, but we see a displacement in the front of the ring. And what, the issue there as far as the displacement, we not only have sort of that displacement, but we're starting to get sort of this displacement. And so we're having a sagittal plane deformity. And in addition, we also see some disruption of the sacroiliac joint on the backside. Bob, can you comment when you start seeing a couple of things? One, could you comment on a binder film and what you look for, and is there any utility in that binder film as far as directing your later treatment? And then when you look at these APC injuries and you see a pure rotatory deformity versus a sagittal deformity, does that change anything for you?
Yeah, I think it does. I think it's pretty helpful in that, as we always say, binders are pretty humbling, and that the binder does a pretty good reduction. Sometimes your reduction is not as good as the binder film, and when you see something in a binder that's this far off, that indicates to me that this may be difficult reduction if you were trying to do this for whatever reason, closed or percutaneous, or some reason you couldn't be in the front to assist your reduction. And when I start to see more verticality, I mean, I think a lot of times when you first start treating pelvis fractures, you sort of think of these as a simple plane, but they're not, right? There's often or typically some multiplanar component to this, and there is vertical displacement almost always in these. And the more you see of that, the more instability there is. So I worry that, we try and fit things that are continuous into discrete little packets, like it's an APC 1 or a 2 or a 3, but like everything in biology, it's a spectrum. And as you start to see more of this, you start to say, hey, maybe this is more than a 2, or it's a 2.5, or it's going to be tougher to reduce, and maybe I need more fixation here too.
Agreed. So let's get a little bit more information. So here's our inlet and outlet films. And so I think, what you see here is, I don't think anything different than what we saw in the initial AP film. We see some external rotation deformity of the left hemipelvis, and then we see some of the sagittal plane displacement. And interestingly, on the right side, he's got sort of this unilateral sacral dysmorphism, and so that can sometimes, cloud the picture a little bit too. And let's run through his CT. You get it. Oh, sorry, that's jumping away. Let me see how I'm going to run that. Sorry, guys. So I can't really stop that, sir. So what I'm looking at in that is, and here's a select view of that, but you see sort of this beaking of the of the of the ala over the, or excuse me, a beaking of the ilium over the ala, and sometimes in the dysmorphs, you'll get a real tongue and groove type of appearance to the SI joint, and that can sometimes create difficulty for you. And now this one to me looks, when I look at that image on that CT, that to me looks like that should hinge close. Now we still have a sagittal plane deformity, but it looks like it should hinge close. And I just want to sort of contrast that with, sorry, I'm trying to get rid of this thing and I don't know how to do that. Like contrast that with this. Sorry, I can't get it to stop. But on the patient's left side, you see this real tongue and groove deformity, and on the left side, you have the same thing, except it's hinged. It's sort of caught over on itself. All right, and so to me, on this particular case, I'm not going to be able to close down that injury on the right side because it's going to block. And so I think when I start seeing some of those beaking over the ala, or beaking over from the ilium into the ala, I think you have to just be careful and be ready that as you try to reduce it, you might not be able to get it. So in this particular situation, what was done was I used an anterior reduction to reduce the posterior pelvis. And so this is using a Youngbluth clamp. And the benefit of the Youngbluth, or the screw reduction clamp, is that I can steer that sagittal plane displacement better. And I can also draw the pelvis forward if I need to. So it gives me a more multiplanar correction. And you can see I'm also augmenting it with the Weber clamp as well to hold both of them. And then For me, usually I will put 2 screws in my plate, and then I will assess the posterior ring. Bob, can you comment about what your thoughts are on that? Do you do something different? What's the controversy of doing that, if anything, and whatever you do?
Yeah, I think definitely people argue about what to do here. And excuse me, the thing they worry about is that you're going to lock in a malreduction in the front. And so if you put a plate in the front and put a bunch of screws in it, then you won't be able to, and you won't have the back perfectly reduced, and then you won't be able to adequately reduce it. And so people who argue that say you should get the reduction, pin it, and then move on to the back, get the back perfect, and then plate in the front. I personally find that when I've done that, I tend to, just personal preference, I tend to lose the reduction in the front. I feel like K-wires are fine, but not great up here. And I tend to more often do what you do, but even more. I'll often put in more screws and then loosen them if I need to. But I've just found that often I feel like I can get the ring pretty close by getting more fixation in the front. And then I just have diastasis in the back and I can overpower the fixation. You can also get abduction, obviously. You can malreduce the back of the ring when you think you have it pretty well in the front because you have this plane can be off. But I tend to err more towards putting a little more fixation in the front because I do feel like in a lot of patterns that gets me in the ballpark and increases the chance I can do the back perk. But there's definitely debate about that. And some people,
Yeah.
say what I just said is stupid and you should keep it mobile in the front so you don't lock yourself out in the back.
Yeah. I mean, I think it's amazing how short-lived a young Bluth clamp is in the front. Like as you start twisting it and turning and doing your reduction, you can't keep doing it over and over again. Those screws die pretty quick. And that's why I go to the plate pretty quick, because I feel like if I don't, I'm going to lose that reduction.
Yeah,
Um,
I think that's a good point. And the other comment just for people, because there's some people in here who who be doing this a lot. It's the mistake that I still sometimes make, right, is you don't put the young Bluth anterior enough and you get in the way of your plate. And it's just remember you really got to get your hand down to put that in more anterior so that you can easily put the plate on.
Yeah. I mean, ideally, if I can split between the 1 and 2 holes on both sides, that's where I'd like to be. But you can see here, even here, I put it right through. I'm right in right in the spot right here of where that screw is going to go in the way. So even if you've been doing it a while, it's still easy to mess it up. The other thing that I'll do is, if you look at the image on the right, you can see I have a pelvic binder on the patient. So I a lot of times will maintain a binder for this surgery, and just move it down to the thighs and then prep the pelvis out just to get it a little bit closer so that my young glute and everything doesn't have to do as much work.
Yeah, I think that's super helpful to sort of, and your comment about you can move the binder down or even tying the legs together, all those tricks that we think about acutely for closed reductions. I think sometimes people sort of forget about that in the OR and just take everything off, and you're losing a bunch of reduction that you have. I think that's a very good point.
Yeah. And so then I went, after we fixed the front, I went and added 2 screws in the back, and you can see the screws are at the S2 level, and you get a glimpse on that outlet of just how dysmorphic he is at this level. He has a really lumbarized S1. So that corridor was sort of gone. But fortunately, where you lose at one level, you gain at the other. And so this was treated with 2 percutaneous transiliac transsacral screws in the back.
Hey, Jason, can you comment? I noticed here you've got fully threaded screws in here, and
Yeah.
I suspect that there was still some, maybe not, but often there's still some diastasis, especially as you climb up the APC realm towards 3. And can you comment on how if you need to make these reduction screws, how you do that, and when do you use this versus partially threaded?
Yeah, this is just something I've moved more to over the years, and so what I will use is I will use a fully threaded screw, but I drill with a 7-3. I do a 7-3 glide hole. So I'll do a glide hole through whatever I'm trying to compress, and then do it as a lag screw by technique. And there are some pros and cons to that. I like that I have all the purchase of all those threads on the far side, being able to pull, and get very, very good purchase. The downside is it's not a pure sort of moment that you're compressing, and so maybe it binds in the glide hole a little bit, is one of the arguments. But this is just sort of the way I do it now. I try to use, for the most part, fully threaded screws with lag by technique.
Yeah, I think that gets you an incredible purchase. I worry about the binding component you said. If I don't have it well reduced, that there's like an angular moment, I need the screw to sort of slide through the slightly mal-reduced. So I often, if I'm trying to reduce it, will start with a partially threaded. But if I don't get purchase, I switch right to this because
Yeah.
this definitely is a lot more purchase.
Yeah. I mean, I'll still use partially threads in situations where I have a contralateral injury that I'm trying not to displace the other side. And then maybe I'm doing some, crazy stuff with like screws from one side and then the other and back and forth. All right. So we started out easy. So case two is a young lady. She was involved in a motor vehicle collision. She has an isolated pelvis injury. She's hemodynamically stable. And this is her AP image. And you can see she's in a binder, and you see a certain level of pelvic obliquity and loss of symmetry. Anteriorly, you see symphyseal injuries anteriorly on the patient's right side. Rami injuries on the patient's right side, and then you have an idea of a sacroiliac dislocation in the back with subluxation, and you sort of have this very high crescent fracture up here with what appears to be some disruption at the SI joint there. And as we look at our additional imaging, it's confirmatory to that level of injury. We see the left SI joint is displaced posteriorly and is lateralized a bit. And I have some select cuts of CTs. I don't have all of them. But we see the sacroiliac joint is clearly unstable. So some of these lateral compression or crescent fractures, you'll look at it and the posterior complex looks pretty good. Like you'll look at it and there's a fracture that goes through it, but the complex isn't blown apart. And then some of them will look like this. And this is to me is a true fracture dislocation. And it looks like there may be, I don't know whether that's just the inferior portion of that constant segment there, but it's sort of caught in the joint. Bob, you have any thoughts on this one?
Yeah, I do. I worry this will be hard to do close for the, stuff caught in the joint. Like you said, when I really have a lot of displacement, my threshold to open up the back really drops. I think this is a very different situation than the hinged APC 2-ish sort of situation. I think, at least for me, this is trickier by a lot to get reduced. And the anterior ring doesn't necessarily make this just pop into place. And so I tend to have a much lower threshold to open this. And if it's an SI dislocation, my default is usually to go in the front. Although you could do this from the back, but I would have a low threshold to I think that I'm going to be opening this.
Do you think that it's almost like there's two ways to look at this? Like you can look at it like it's a sacroiliac dislocation with a small fracture, or you could look at it as it's an iliac wing fracture that you reduce the wing and it reduces the SI joint. And is there anything or any is do you look at it like that, or is there certain situations of something where you look like you might think about it like, okay, well, this is one that I really want to put the wing together, or this is one that I really want to treat it like it's a SI dislocation, or I'm going to do both of those things. It's part of pants over, pants and
Yeah.
or belt and suspenders.
Yeah. I'm not sure what the right answer to that is, but the way I think about it is just the larger the crescent fracture is and the more it comes anterior, the more I think about that the crescent will hold everything together, as opposed to like it's really an SI dislocation that just happens to have a little crescent in the back. And so I do think the size of it, and it's definitely, it's easier, to be honest, to cheat with 3Ds now, right? Like you can really very easily see kind of like where exactly is that fracture, and what am I going to get from the front, what am I going to get from the back. And so for me, the size of the fragment I think does change it. What about for you?
Yeah, I think usually I'm probably going for the SI joint first and then augmenting with the iliac wing. Like I want to get the SI joint reduced, and usually that's going to get the ilium fracture done as well, and then I augment with additional fixation. But I'm not sure. I think there's some situations where that fracture, that crescent fracture, is kind of such a tasty orientation or line
Yeah.
that you just put it together and it wants to sit. I think as the crescent gets more comminuted or more posterior, that was in this particular case. That you look at this and you're like, oh, well, that's not that far back. But if you think about where you need to be from the front, to get to that crescent, it's pretty far around the back. I mean, you'll have good access to the top of the SI joint, but that crescent gets a little bit hard to instrument. At least in my hands, I have a little bit of trouble getting back there.
Yeah, I think if you're coming from the front, like I was saying, you're essentially ignoring that, right? You're just
Yeah,
going to treat it like an SI dislocation,
yeah.
do whatever you do for that.
So this one, I was a little concerned about how far back that crescent was, and I was a little concerned about that stuff in the inferior aspect of the SI joint. And for me, I do struggle a bit to get low in the SI joint from the front. I sort of get to the top part really well, but the lower half I struggle a little bit. And so I chose to do this one from the back. And so this is this is some clamp placement from the back, actually, with some reduction screws in. And so this approach is done, elevating the G max off of midline, usually off of midline or off of the ilium, depending on where you're trying to go. If I'm trying to go to the sacrum, I'll try to take it off midline. If I'm trying to get to just the ilium or the inferior aspect of the SI joint, I'm okay taking it off the PSIS. And then that gets you access to the sciatic notch. You need to release the pelvic floor ligaments, but you have access to that inferior, sort of this inferior aspect of the SI joint. So that's the part of the SI joint that you get to see from the back. And for folks that haven't done it a lot, you sort of feel like, oh, well, I'm going to see and I'm going to have access all the way up through this area. And you really won't. I mean, you will from the standpoint that before it's reduced, you could take this and lateralize everything and look down the SI joint from sort of over here, and sort of look in here. But once it's reduced, you don't have access to that portion of the SI joint. And so most of this reduction then is occurring through the notch. And then, what I was hopeful for with this approach is that I'd have good access to that crescent fracture, which is sort of coming up into that direction. And so this is sort of how you can palpate and feel the front of the SI joint through the sacrum, through the notch. And then there's, described ways to place a clamp across the SI joint through the notch. Usually it's an angled Mata clamp. And so you can see here, once those clamps were placed, the reduction of the posterior ring looked pretty good. And then you sort of move your image forward and you can see that in fact then reduced the anterior ring. And that's kind of how, it's described that it should work. I can tell you that it doesn't always work like that. And then this is what we were left with. And so you see a combination of some sacroiliac screw fixation, as well as some screw fixation in the ilium as well. And in this particular situation, I left the front alone. This was a little bit of an older case for me. I think I've changed my practice a bit over the years, but there's definitely some argument that once you have the back reduced, you could let it fly. I will tell you that, in this particular case, even though we had a pretty good reduction here, you can see that over a 6-month period, she heals in an acceptable position, but there is some residual displacement. Bob, what do you think about, leaving everything hang from the back on something like this, or and like your threshold for doing that, depending on the position you approach the posterior injury?
Yeah, it's one of the reasons why I try and come up with some excuse to not do a posterior approach is that it definitely, maybe it shouldn't, but it changes my threshold to fix the front. And when you're supine, it's not such a big deal. And yep, you should do the right thing for the patient. I get it, but you got to flip the patient over and come around to the front or do a different approach. And so, another approach to this case, right, would have been to open up the front and even, plate all the way across the front and, get similar to the first approach you did and then go in the back, but you wouldn't be able to, as you said, you probably wouldn't get much fixation, if any, in the crescent fraction. Then you just had screws, but you'd add a plate in the front. And we definitely have cases, I do, I know everyone does, where you can't fix the front for some reason. There's wounds, it's a terrible open pelvis with contamination and other stuff. And we leave them open in the front, big, even symphyseal diastases and things. So you can do it, and it works sometimes. As you said, it's not as stable, right? So in these very unstable injuries, you have more of a chance that you'll get some drift for sure. But sometimes you have to, because of the whole clinical picture.
Yeah.
And I think like you, the other comment I was going to make is over time, I think the field has moved towards more and more fixation, right? Like in that previous case, if we were doing this 10 or 15 years ago, we'd be talking about, APC2s, do they need surgery? And then the big fight was, well, if you need surgery, because someone will close down if you don't operate on them. If they do, which was true. So now we stopped arguing about that. We're going to put fixation in the front. Do they need screws in the back? Now that's not a fight. Now we're just talking about what screws do they need in the back, and should they take the other uninjured joint like that?
Yeah.
Like the fact you had that in that case, that's not even an argument now, right? Like that was total heresy, 10 years ago. So the field is just moving towards more and more fixation. And part of the reason is there are mechanical failures. There have been studies on this. The mechanical failure rate's kind of high.
Yeah. I mean, and that's to my point why I think I've changed too, where I will try to go longer with screws and I will try to fix if it is an operative ring where I am managing it operatively, I'll tend to fix the points of the ring that are disrupted. All right, third case, 20-year-old skateboarder into a wall. He has a severe brain injury, diffuse axonal injury. He's pretty sick, and he has this injury. And so we see a right-sided pelvic ring disruption. He's got a crescent fracture that's coming down into a sacroiliac disruption here. And then he's got a pretty unstable looking anterior ring injury with segmental rami injuries. This is a CT scan. Let's see if I can. No, I ain't getting that to play. Let me see. Nope. Okay. And so what his CT shows is sort of mid-level SI joint fracture. So the crescent comes through sort of mid-level on the axial cut, and there's a little bit of sacral impaction in this area too. And so it's not only is there the crescent fracture, the SI dislocation, but then he also has some sacral impaction. And so he's sick. He's sitting in the unit, and he's about 2 weeks out at this point, and we just can't get him to the OR because he's so unstable. And you can see that this is kind of the displacement an untreated bad lateral compression injury will have, where they have sort of shortening of the right limb, internal rotation deformity of the pelvis. So any thoughts? Oh, there's your CT, so you can get a little glimpse of that there, and you see a little bit if you look at the difference between that ala and this portion of the ala. You can see that one's punched in and kicked up a little bit. Any thoughts on this one, Bob? With also in constellation of the entire ring injury that you see.
Yeah, I mean the 2 weeks adds a lot here, right? So it's going to make it a lot tougher, I think, to get your reduction. And especially these sick, banged up patients, you may not want to open up the front of the SI joint, but I think you're going to really struggle to get that reduction percutaneously. Maybe you're going to show us you did, but I think that is going to be hard, and you don't have an easy anterior ring assist where, like a symphyseal disruption or something. You've got something more complicated in the front that you can much more easily malreduce that doesn't help you in the back. And so I think for me, this is a tough one where I would be thinking like, this is gonna be a hard case. I'm gonna have to open the front and the back potentially. And that impaction, so I think that's something that's really easy to miss. That's a subtle finding that I'm not sure I don't know that I would do something about that, but I think it's important to notice because it may throw off your radiographic reads, and you may be more confused than my baseline rate of confusion. So I think that's a good thing to notice. I think a lot of people wouldn't have noticed that. At least I might not have for sure.
I think it's funny because I think that this would have been a very different injury. If you had it at this stage, right when he came in, I mean, honestly, to me, the ring looks pretty good at that point. Sure, it's a real unstable injury, but at day one, maybe this is more of a percutaneous procedure or, limited open anterior or something like that. But, once the time goes by and the deformity sets in, I would agree with you. For me, this is going to need something open to get it reduced because it's pretty far off right now. So this one I did from the front, and the reason I chose the front was because I felt like I was going to need to what you alluded to. I needed access here, but I also needed access here and here to reduce the front of the ring too. And one of the nice things about, and you could make an argument and say, okay, well, I want to, for whatever reason, I want to do things from the back. You could, but then it involves a flip and a change in position. And I'm not real keen on putting people with real severe brain injuries prone. And, he had a lot of other stuff going on. And I think supine was a little bit better for him, as well as for me. It gave me more access around the ring. He could sit in an elevated position. We could keep his head pressures down. So, this is a lateral window approach. I tend to always add an ASIS osteotomy. However you want to do it, I think releasing this off of the anterior crest here really helps with your lateral window exposure. I don't do it for every acetabular fracture, but for these, when I need to get back to the SI joint, it really mobilizes the abdominal wall and loosens things up, so you get access in the back. And then it's elevation down to the ala, and then what you'll feel is this gets to be a deep hole sometimes pretty quick, and so I'll look for those fibers of the anterior sacroiliac ligaments, and I'll mobilize them off the ala. You don't see the L5 nerve root routinely in this approach. You will see it if you do cadaveric dissections. You'll see it, but I don't see it usually in the clinical setting. And then through there, I usually will I tend to put a Homan of some sort into the sacral ala. And sometimes I'll put something over the front of the sacrum as depicted here.
Hey, Jason, can you comment a little bit? You mentioned the ASIS osteotomy, and I think that's something that's evolved over the last, whatever, some number of years. Can you comment? You made some comments that you didn't, would can you give us a hint about how you fix it, how you do and you said, can you just cut the inguinal ligament off and reattach it? Do I have to make the osteotomy?
I think you probably can just cut it off and sew it back down, however you choose. I tend to, sort of plan for it, and so I keep a soft tissue sleeve attached to it and do about a centimeter, centimeter and a half deep, and about a centimeter, centimeter and a half bottom cut. And then I tend to use a 3-5 screw that sort of goes, sort of up in that direction at the end. I don't pre-drill it or do any of that stuff. What I'll do is at the end, I sort of show it to myself. I drill with a 3-5 glide through it. And then once I drill the glide through it, then I reduce it and I put my 2-5 drill bit in and I compress it. That seems to be a quick way to do it. I put a tenaculum on it to hold it, but that can always be a bit futzy. And I think that's the reason why some people just sort of do a peel there, because then they don't have to deal with it. You go through a difficult case and then you got to put this little chiclet back on, and sometimes it can be a real pain in the neck, but I still do it with the bone. And I think some people, I don't know, I think Saj does like an oblique cut when he does it. And so people do different things. And I think they all probably work. What do you do anything different?
I do an oblique cut, and I think that glide hole is a good idea. I don't do that. Maybe I should. And I rarely, on purpose, cut the inguinal ligament off. So I like you, just like to have a bony thing. But I know people who do just take the soft tissue off.
Yeah, I think the one time that it sometimes happens is if I'm doing something and I didn't plan ahead that I was going to do an AS osteotomy, and then I realized later that I need to, and I already have sort of a soft tissue dissection that doesn't make the osteotomy as palatable. I'll do the peel.
Yeah, that makes sense. It's good to know that that's an option.
Yeah. The other place that's really useful to put a retractor is to make sure that you finish your dissection over the iliac crest in this direction and sort of going back towards the spine. And then I'll tend to put a Homan over the top of the back of the brim. So I'll usually get something up in this direction that's sort of pulling that way. Over the top really helps. So I'll take some time and make sure that I really clean off all of this stuff up in here, because when that stuff's all adherent, it just closes down. This hole just closes down so much. You see these beautiful pictures and drawings and how much of the front of the pelvis you can see, and when you're actually doing it, you're kind of like looking down through a little window, especially in a big patient. So this is sort of where we were with our inlet once we had our approach done. And to your point of, that it could throw your reduction off if you don't understand that sort of sacral impaction. That's that sacral impaction. So if you're chasing that and trying to reduce to that, that could create some challenges for you. And then a lot of times the workhorse reduction in this front of the pelvis is some sort of screw reduction clamp, whether it's a young Bluth or using a Farabuff sort of straight in. A screw in the sacrum and a screw in the ilium. And as long as you're paralleling the SI joint with a screw down the ilium, like as long as you sort of go this way with the screw, you can get a nice, big, long, powerful screw. As soon as you sort of go this way with the screw, though, they get really, really short. So as you guys are doing this, think about how the ilium goes back towards the PSIS and goes inferior, and you have this sort of nice long channel of bone you can put a screw down rather than putting it out lateral. The space gets real tight though in a hurry, and you'll need to decide, do you want to put this clamp on, are you going to put the clamp on sort of up here? Are you going to put the clamp sort of down here? You got to sort of plan where you're going to put it, because you're going to run out of room. And I run out of room, and every time I do this case. Do you have any pearls, Bob, or anything you do that's different? Or
No, I think that's a great point. One of the other technical problems that I see is that, you can get greedy about plating over the SI joint. You want to have a bunch of screws on each side, and there's not much real estate for that. And the orientation becomes vertical very quickly. So it sort of switches from horizontal to vertical. And you can, again, like sort of open up the bottom of the SI joint. Like you can mal-reduce it with the plate. And so I think often, for me, I'll put screws in too. I just won't just do the plates up above, and you can get into traffic issues, and you can put the screws in places that give you trouble. But I'd use fluoro for, putting those screws in, because you can put those in bad places. But generally I should still do kind of, a small short plate in the back and a plate in the front, and then screws through the middle, is what I try and do.
Yeah, early on, I didn't understand the deformity that I was going to introduce with with these reduction tools. And so, what happens is, as you close down up here, there's a tendency, this is what Dr. O'Toole is describing, is that you gap open distally. So you close it up top, and you sort of swing the bottom of the SI joint open. So that's the one thing. So it's sort of a sort of an abduction deformity. And then the other is you can internally rotate it too. So as you're clamping down sort of in this direction, you preferentially sort of close down up here, and you gap open back there too. So to have something to neutralize it, so your screw to neutralize it, as you're putting your reduction clamp up in the front to squeeze it together, that neutralizes that whole thing, so you don't gap it in the back. Similarly, you could do the same thing here, where I could have a screw, if I even have a screw coming, something like that across, or put my wire in or something like that, as I'm doing my definitive tensioning, I can have the screw in to neutralize that deforming force.
It's almost like these plates are great. They're awesome at getting the verticality of it, right? Because they're flat right out the joint, and they get that reduction really well. And you can feel on the front of the SI joint, so you can kind of get the front back. But as you mentioned, the other two angles, it doesn't necessarily get. So it's sort of like unicortically plating any other, like a diaphyseal fracture, where you only see part of it though.
Yeah.
And you can, as you just very nicely described, you can gap the other sides.
So in this situation, you see sort of a montage of like open reduction techniques and some percutaneous techniques in the back, and that neutralization screw. And then once I had things close in the back, then I came around and addressed the front. And that particular ramus fracture to me was a pretty difficult segment, and I thought it was better to just sort of span across it rather than sort of work to try to get each of those segments back and gain stability.
Always need two screws in this situation above the acetabulum, Jason? Those screws are usually killers. Can you just, is one screw enough, or you try and get
No,
two always?
I think it's probably fine to have two. Sometimes when you're doing these patients, especially if you're doing them late, sometimes sweeping around from the inside can get a little hairy because things are scarred down. At least for me, and as I'm doing that dissection, I'm just waiting for that flash of something bad to come out, and so sometimes one screw's perfect in that situation because I don't want to go anymore. But yeah, I think one, especially something like this where you have pretty rigid stability, or good reduction, what I thought was a good reduction in the back, fairly stable. I think one screw bridging it out probably would have been fine. But
Looks nice. That's a tough
you get a
case.
hit. You can see the that sort of where that little ala is off still. All right, where are we here? We're at 8. Good. Okay. This is a 17-year-old kid. He's in a high-speed crash. Another one, real sick. He arrested twice in the field. He's hemodynamically unstable. Sort of the real deal. Bilateral femurs, tibias, and so he comes in with his pelvis fracture, and we'll ignore this sort of low posterior column thing that he has here in the back. But He's got SI widening, sort of blown apart SI joint. I don't know if you guys can see it, but he's sort of had knocked off his transverse process up there, and then he's got some sort of hinging of his. He's got something going on at his symphysis where it's not quite right. There's his binder film. And again, binder film shows he's still pretty wide in the back. He's not really closed down. And I don't know if I can make this play. I don't know what I did. This doesn't work now. Let me see. Try this. Look at me. Look at me. The
That was
Zoom.
so impressive.
You
I'm
like that?
amazed.
All right. So cruddy outside image, but what you can see is he's got a blown apart SI joint on the right side, and I'm not sure what else he's got going on underneath. I guess he had a low transverse is what he was. All right. So he gets a resuscitation frame. He gets his belly open. He gets coiled. He gets a resuscitation frame. He gets I think he had ECMO put in. So that's what this sort of big line is running up his. All right, let me get to that. Sort of running up in here. This is a big ECMO line. He's got frames on his femur. What are your thoughts, Bob, on these frames? I mean, we don't see a lot of these resuscitation. I mean, we certainly don't do as many resuscitation frames as historically we have done, but I still think there may be a role for it.
I think there's a role for it. I do it sometimes in the crashing patient. I think they're very easy to put on really quickly. You don't need fluoro. I think they do something. I think mechanically, like all anterior X fixes, I think they're not great at all. It's very difficult to hold stuff in 3 dimensions. And I think in general, the binder does a much better job. It's just mechanically better. It's sort of circumferentially is able to reduce stuff. And, for something like this where you have real displacement, you can see it. I suspect if you drove on the greater trochanters, you would be able to, with the X fix tightened, you would probably be able to move this. So I don't, I do it. I think it's better than nothing. It gives the advantage of getting the binder off, but I don't think they're great mechanically if you're trying to bring it together. I was going to ask you, in cases like this, is there somebody, were you thinking about, this patient was too sick maybe to do it, but resuscitation screws, this is something people used to talk about even,
Yeah.
No fluoro, just put the thing in and save the guy's life or whatever. I don't hear as much talk about that, but I do hear more talk about, look, it doesn't take that long to put an SI screw in. Let's stop for a minute and get this close. What are your thoughts? Is there still a role for that for in
Yeah.
these sick
I mean,
patients?
I don't think I was involved in him initially. I think somebody else took care of this in the front end, but when I see that kind of displacement or just lateralization of the ilium, like that to me is like begging for a screw to go across it. And even if it's not perfect, it's kind of closing down the ring, and it's part of that. For me, it's part of the resuscitation, right? It's trying to tamponade off some of this blood loss that the kid's having. And so I think, I have put in resuscitation screws years ago where we put them in and they were open injuries and things. You sort of put your hand in, feel the sacrum, and just shoot it. But I think we've gotten pretty facile at putting screws in. And I think, a lot of times we're set up ahead of time for the potential that we're going to put it in. And so I think that maybe that line's blurred a little bit. So it's not so much a resuscitation screw, but maybe it's an SI screw that we're putting in with maybe an imperfect reduction. And I think I will try to do that if possible. Like if if all things were equal and the kid wasn't dying and coding, I would probably have tried to put one in on that injury that I'm looking at right now.
Right. And, obviously if they're doing chest compressions on them, you're probably going to not be putting in an SI screw, but there's probably a spot where the patient's sick and actually, to your point, like they actually need us to stop for a second and, stop the bleeding maybe. So I think that's definitely something that has changed and people need to think about more.
Yeah. I mean, this is a really good point for like, you got to talk about it ahead of time because you're probably on the wrong bed or you're in the wrong room or, it's a hybrid room. So there's a lot of other factors that, you can mitigate some of that, but some of it you don't have control over.
Yeah.
So this is kind of where he is. And it's what we had talked about, right? You have sort of this lateralization of the SI joint. it's sort of sitting out here. And I mean, it's begging for some of that. And so this is what he looks like after his frame. And again, same sort of thing. You see this fairly significant lateralization and displacement of the hemipelvis. And the problem is, like, this is how he's laying, right? He's connected to a huge ECMO machine. He's sick as snot in the unit. And he's got, open fasciotomies. He's got all these sort of tubes running up the front of his body, cortices and ECMO stuff. And this is something that, a lot of times we don't talk about because we're focusing on the X-ray and we're talking about, the pelvic ring mechanism and the ways to get there. But a lot of times that's inside of somebody like this, and you need to maybe come up with something different to do in these folks, because you're not going to be able to do an open anterior. You're not going to be able to flip them prone and do a prone open approach with these tubes. I don't know if any, how many people in the audience have, operated on people with ECMO tubes, but it's a tube as big around as your thumb, then all their blood's flowing through it. And, you're just scared to death in the operating room that you're going to trip over the tube and rip it out. And, it's going to be a disaster. So, in this situation, it was a good 3 weeks before we got to the kid. He had, his lactate was, around 9 or 10. He had an open abdomen, fasciotomies, and on ECMO. So,
can I make another comment about that, Jason?
absolutely.
Just more ECMO fears. They're also almost always very anticoagulated. So, even if they didn't have that, and I think I've heard of 2 cases of ECMO tubes getting pulled out inadvertently, not necessarily in the OR, but one in an elevator. That does not go well, as you can imagine. And so, you need to take that stuff, sort of obvious to everyone who has to operate on ECMO patients really seriously, and think very carefully before you start to saying, oh, well, I'm just, who cares? I'll just be careful. You're swinging the C-arm around those. You really need to be careful, obviously.
Yeah. So, I mean, this kid, my worry was, was I going to be able to get it reduced to 3 weeks with anything other than an open approach? And so if you're going to do something like this percutaneous, you need to have some sort of adjunct to connect them to the bed. And I mean, this is a star frame, but there's different sorts of frames or X fixes you can connect to the bed and try to stabilize the intact pelvis so you have something to push against. And so, you use a series of pushers and ball spikes and stuff like that to sort of control things and close it down, and then augment that with your screws. And, overall had a pretty good reduction on this, on something that was, 3 weeks out. Again, he's got an anterior ring injury. He's got a symphyseal disruption. We're not going to get to, I can't open his belly for anything. So, I left him in a frame. And this is how it winds up. And is there some, changes that happened at the symphysis? Sure. But overall, the ring is pretty good from, at least in my opinion, from where we started to where we are, where we are now. So I think it's important to recognize that even though you have things you want to do, I think this case brings that out. Like, I would deal, if you just showed me the X-ray, I probably would have done something very, very different, both in the front and the back. But because of what it comes wrapped up in, I think sometimes you need to alter, what your plan is. Bob, do you have any comments on that?
Yeah, I'm just impressed you could get it that close, at that time out, and it's so diastase. I mean, you have no financial interest in the star frame, but
No.
it's pretty impressive that you were able to get that percutaneously that close. I agree with you. Your comment in general obviously is a very good one about how important the whole patient is and all the other injuries. I personally over the years have really tried hard not to treat symphyseal dislocations without a plate, but this is of course an example where you had to do it, and it seems like it worked out fine, actually. Hey, there's a question in the chat for us about C clamps. I know we kind of went through a period at our shop where we had some interest, and we're doing it a lot, and we still get trauma surgeons who will call us at all sorts of hours and say, hey, come on in and put the C clamp in. I just wonder, after that experience, are you a fan? Are you not a fan? Is it somewhere in between?
I'm somewhere in between. I mean, we weren't putting it on. We were putting it on the trocaners, first of all, and it was a little easier to put on the trocaners because it didn't. One of the worries that I have about putting it on in the right spot, excuse me, in the back of the pelvis, is that it burns a big hole and leaves you a big hole where you're going to put your SI screw. And so we thought we could put it on easy and fast at the trocaners. It's been described in the literature by others. Archdeacon and some other folks have written about it as well. And so It works and it closes the pelvis down, and it's nice because it gets the binder off. You don't have to do anything with an X fix, and we can leave. That was nice because then when the vascular guys were doing everything, I didn't need to stay there to sort of move anything around because you could sort of rotate and flip that frame around on the pelvis. It would sort of just pivot on those pins. The device itself is pretty finicky. Like if you put it on a few times, it just because it's a square, sort of like at right angles. It has to slide like straight in on itself. Like there's not a lot of play like this, and I definitely had trouble. I know Bob did too. Of like you put it in a little off axis, and then you're trying to squeeze this thing down, and you can't get it. I think there's a role for it. I think it's a cool device to use. It's useful. It's expensive, and we destroyed them. I mean, we wrecked a few of them. So I
The
think
other
it's
thing I
fine.
think was tough about it was that the way we were doing it, the so-called T-clamp, was it was on the femurs. And so you kind of, the femurs can't move now, right? So it's just, it was sort of like you were X-fixing the femurs to each other. And so,
Yeah,
and you had a few that fell off and things because you tried to move the femurs around. And so that was sort of a little bit of downside. I realized that, you're doing that too with a binder, you're, crushing the femurs together. But yeah, I think our general surgery colleagues liked it. They did like it though. So for the reasons you
yeah,
said in the beginning.
yeah. I think it's a useful. Again, I just think it's another tool. I think it's useful to use, and um, yeah. All right, last case, and so this is a 57-year-old. He came in. He had a bad motorcycle crash. He open scrotum, open lower abdomen. So his anterior ring stuff was pretty beat up. He had some mesenteric stuff. He had an open abdomen, and wound up getting a fair amount of surgery early on, non-orthopedic surgery for his belly. And so this is his presenting film, and you can tell when you look at this, you see a pretty significant anterior ring injury. But when you look and you see the sacral morphology is like gone, you have a bad sacral fracture. And so what you look at his right side and you kind of see none of the Shenton's lines of his foramina, right? So you look on this side and you see sort of these Shenton lines here. Here you see a little of the lowers, and then it's just sort of a void up there. And so he had something like this. And so you get some of these, you're gonna get these. They're pretty nasty sacral fractures that are widely diastased. They're associated with a spine injury as well. So you'll see the 5-1 facet is blown apart. They're super unstable injuries. And the problem is they usually come wrapped up in super sick patients like this guy. And so he got initial frame, kind of a provisional reduction with some traction. You see he looks better. As far as his, height of his ilium, he looks better. He's got this open stuff down here. And so this is kind of a no-fly zone anterior. And this is where he sits. And I think he was probably sitting there for about 4 or 5 days just because he had so much stuff going on. And so when you start talking about these complete sacral fractures that are sort of zone 2, zone 1 type fractures, high incidence of neurologic injuries. And I just have not had early on. I tried to get some of these closed and do them perk, and I just don't think they worked out very well. I feel like there was some level of that I needed to have that sacrum reduced to itself. And where the sacrum is usually intact in these is going to be posterior. You're going to have some sort of posterior sacrum that won't get you stability, but it gives you a read on where the sacrum should be. And so I'm going to move through this a little bit quicker. But so this is a prone open approach for this kind of sacrum. And I do think you need some table assisted stability because you need to pull this leg down a lot. And you can see here I have a Chance pin in the PSIS, and I'm not only pulling him back, but I'm sort of pulling him down, but I'm sort of pulling him back. You need to have they need to be attached to the bed or to the frame, somehow. So you have something you can pull against to manipulate them. If you don't have them anchored to the bed, you kind of lift them up. And so some people will also use sort of distal traction down here on the leg too. I think those are all reasonable options. And then through the open posterior approach, usually what you start with is some sort of small fixation along the intact portion where you have a tension failure of the sacrum. And these are just little, they're probably like little 2-0 plates. maybe, maybe something a little bigger than that, 1.5 or 2.0 plates to sort of hold the reduction, hold the position of the sacrum, and then you're going to go ahead and add your sacroiliac screws. And then when I have a fracture that's this unstable, excuse me, because you have that L5, not only because we have just that sacral fracture, but you also have that sort of spinopelvic complex at L5 that's blown. To me, this is somebody that needs lumbopelvic fixation. And so I will have them come and do a lumbopelvic after I reduce the pelvis. So I think it's important to you have to get the pelvis reduced before the lumbopelvic goes in, because they won't worry about reducing the pelvis, and there's no real ability to reduce the pelvis once that stuff's in. Bob, do you want to comment on
No,
lumbopelvic?
I think that's a super important point that gets lost. And sometimes people will say, well, we'll have them reduce this with the lumbopelvic fixation and just put that in. And then you start to say, well, why, that fixation's so good. Why do you even need us? And I think what you need us for is to get the thing reduced, because I think that's tough for them to do. And I like you, it sounds like, think about this as in situ fixation. The question I had for you about posterior approach, one of the knocks on posterior approaches is that people have said, oh, it's has a high rate of wound problems. And as you said, these patients that really need it, they have all sorts of other stuff, and they
Yeah.
have morels and all sorts of problems. Do you comment on that? And do you think that's overblown? There's also been some papers out there that show actually maybe that's not true, pretty low rate
Yeah.
of complications.
Yeah, I mean, I think that big series was by Stover years back. There was a bunch of posterior approaches they did, and that used to be the big knock on posterior approaches, was because it was bad soft tissue. And at least my recollection of that paper was, with soft tissue handling and appropriate soft tissue management, there wasn't a problem. And I think that is true. I think in that paper you probably also have, a lot of patients that probably didn't need a posterior open approach, that so you're having some fractures that maybe don't have the level of soft tissue injury. I feel like these patients, like this one I'm showing here, I think it's almost about a 50-50 chance that you're going to have some wound complication, just because their posterior tissues are so destroyed, and you can't wait them out. You got to sort of do something. And so he fortunately didn't have a problem, but I feel like it's not uncommon with this level of injury that you're going to have it. But I don't know what your other choice is. I don't. I think if you leave them be, they get an unacceptable pelvic deformity that makes walking and sitting almost impossible. And I also think you get a non-union, and then you think this is bad early. When you get a non-union in that area, in my opinion, that's even worse. A non-union malunion. So I kind of feel like you're taking the least of two bad options. But what are your thoughts?
No, I think that's very reasonable. Like most things in the pelvis, we don't have trials or, anything comparing one option to another, but sometimes you only have one thing. And as you said, sometimes you have multiple bad options, and,
Yeah,
non-operative is really tough in these. Sometimes they have, they've been embolized, they have a bunch of dead muscle in the back that you're not so excited to get into. And sometimes, like you said, you wind up with, essentially unacceptable reductions or fixations or situations, and you decide to do that. And they're kind of unanswerable questions, right? You get in really
yeah.
tough trade-offs you have to make in this job.
So I left this guy alone in the front because I just couldn't. His soft tissues were such that we couldn't do anything. But he wound up healing, and he's actually done pretty well. His main dysfunction is neurologic dysfunction, and I think that's what most of them have, is the neurologic dysfunction, and neurologic stuff really is the driver for poor outcome. So we're done. That's essentially the cases for tonight. And so the summary is, as we've learned and as we've gone over, there's a lot of different posterior injuries you're going to encounter, and there's a lot of different techniques to use, and trying to come up with what technique to use is really based on the injury pattern, your ability to achieve a stable reduction, and then the patient factors, right? The patient factors are some of the most important things. So that's what we have tonight. I know we ran a little bit over, but I did want to leave a little bit of time if there's any questions. There's, our emails. If you guys have questions, you can feel free to email us too in the future. And I don't know, do we have anything out there? Was there any other questions, Bob?
Nothing floating in the Q&A. If somebody wants to type something in real quick, we can hit it in the last few seconds here. But right now, I think we're up to date on the questions in the Q&A. Oh, there's one right now. So the question is, what's your experience approach for patient has associated viscous injury with colostomy? So it's a tough question. How
I
does
mean,
that affect you? Do you do anything? Do you try and talk to the
yeah.
surgeons before they do it and say, hey, don't put the, bring it out here? Or do you try and influence how they treat it?
Yeah, I mean that's the number one thing because they will 100% put it exactly where you're going to be with your incision every single time. So if you can talk to them about it, sometimes they can do sort of a transverse loop osteotomy or colostomy that's higher in the abdomen. You can talk to them, and sometimes they can move it if you tell them. If it's close, I try to drape things out. I try to get it out of the way. But that's when we talk about pelvic rings and managing pelvic rings. It's incisions, tubes, bags, all that stuff comes into, your surgical approach. The best thing I think is talking to them ahead of the time. If it's in your way, you got to drape it out the best you can. And sometimes it precludes your ability to do an anterior approach.
Yeah, it seems simple, but a lot of the errors we make in these complex patients are just straight communication errors where, you didn't talk to the person and they were thinking you were thinking something else, and
Yeah.
then something not so great happens. And we see it for sure in the open rings where you're, down in the rectum or other areas. And I think you kind of have to keep showing up for those surgeries, both teams, because you both need each other to do those debridements, et cetera. And these complex patients, they just require a lot of teamwork. Another question is tips for identifying occult SI joint injury while in a binder, or should you think of it? So just you said start with the easy part. So you get to the OR, you have we've all had this situation where you have an APC 2 or 3 on one side and you fix it, and then you get done and you notice you opened up the other side, or there's an injury on the other side that it looked perfect initially. There was no injury on the CAT scan or
Yeah.
anything. Do you
Yeah.
do something?
Well, I ideally, if I'm going to cross into the other SI joint, I'm going to be worried about there might be an occult injury there. I mean, you just got to worry about it all the time that there's some sort of injury you haven't appreciated there. I don't have a great way to EUA it or to look at it, especially if you're going to be fixing somebody in a binder. So a lot of times I'll keep a binder on and I'll keep it low. And in that situation, maybe I don't even know that it's there and I just go across it and we don't even worry about it. But I think the common place you'll see it is you push it. Everyone wants to do transiliac transsacral screws. You go across to the other side. As you put the screw in, you see it push it open. And so in that situation, you pull the screw back. I'll put something in from the contralateral side first, and then I'll put my transiliac transsacral. That's what I do. I don't have a routine stressing or something like that. Do you do? What do you do?
In LCs, I try, if I can remember, to go to the other side and make sure it's on LC3. I just feel like I've made that mistake enough times that I just quickly image the other side. Because typically I'm not often in a binder in that situation because of internal rotation deformity,
Yeah.
and make sure that when I externally rotate, I'm not opening it up. Having said that, we just had a case recently where that sort of happened, where it's bilateral APCs where we probably opened up the other side with an occult injury. We eventually came back, they had to come back for something, we fixed it. But I think it's a good question, and especially with the point about the binder. But I think your idea of like maybe just, since we're so often coming across the ilium with fixation, you could potentially just fix it,
Yeah.
even if
But if
it's
I
on.
knew I had the subtle injury on the one side, I would start, if I knew I had it already, I would start on that side and then do everything else from the other side.
And that's exactly why I've gone to
Yeah.
stressing or imaging that other side, because of what you just said, right? Because it changes my tactic. I'd rather
Yeah.
start there.
Yeah. All right. I think we need to wrap. We ran over a little bit. I appreciate everyone's attention tonight and interest. Just a heads up, coming up on January 23rd, George Russell is going to be giving a webinar on, I think it's associated acetabular fractures. It looks like it's a pretty interesting topic. So tune in for that. And thanks again for all your attention. Bob, thanks for your help tonight. It
Thank
was
you.
great. And
Thanks for
there's our
thanks for
email,
bringing all the
guys, if you need
cases.
them. All right. We'll see you guys.
Good night.